Yes, the topic is contracted pelvis and cephalopelvic disproportion and pelvimetry. Cephalopelvic disproportion and contracted pelvis are two major causes of dystocia. Dystocia means difficult labor. So, our learning outcome in this subject, at the end of this lecture, you must be able to define what contracted pelvis and cephalopelvic disproportion are and must be able to distinguish between the two. Secondly, you must be able to recognize the different pelvic types and their variants. Thirdly, you will be able to outline some of the causes of contracted pelvis and be able to diagnose contracted pelvis through history, clinical pelvimetry, and probably X-ray pelvimetry. And lastly, you must be able to manage labor in cephalopelvic disproportion. Contracted pelvis and cephalopelvic disproportions often results in difficult labor. And difficult labor often results from the three components of natural labor. And these three components are the powers, the passage, and then the passenger. The powers are of two kinds. The primary power is derived from the action of the uterus, uterine contraction in labor. And the secondary forces involve the voluntary muscles of the diaphragm and then the anterior abdominal wall. Both these forces must be well coordinated as to bring about expulsion of the fetus through the vagina. And the passage is usually referred to as the pelvis, the bony pelvis, the bony pelvis. And our discussion we deal mainly with the pelvis. And the third power is the passenger, which is the fetus. Both the passage and the passenger may actually be a cause of prolonged labor or difficult labor, as we see. The passage are of two types: the soft passages of the back canal, supported by ligaments and fascia, and then the hard bony passage of the pelvis. So we shall concentrate more on the bony passages and the pelvis. I want to believe that you can still appreciate your basic anatomy of the bony pelvis. The pelvis itself looks like a basin and is divided into a true and a false portion, which are separated from one another by the pelvic inlet. The true pelvis is the only one that concerns the obstetrician. The true pelvis is the only one that concerns the obstetrician. And the true pelvis is divided into upper, middle, and lower pelvic straits. The true pelvis is divided into upper, middle, and lower pelvic straits. The upper straight of what we call the true pelvic brim, or the obstetric inlet, by itself is not a cavity in the real sense. It has no measurable depth. It has no measurable depth. It is a thin body over whose longest diameter runs transversely and is banded anteriorly by the upper surface of the pubic symphysis and posteriorly by the sacral promontory and laterally by the iliopectineal lines. Again, this upper straight or the true brim is banded anteriorly by the upper surface, the posterior surface of the pubic symphysis and posteriorly by the sacral promontory and laterally by the iliopectineal lines. It has no measurable depth. It's a thin body over whose longest diameter runs transversely. And it's not a cavity in the real sense. The lower pelvic straight or the low cavity or plane of least pelvic dimension or the obstetric outlets. These are the various names we call it. The obstetric outlet or the lower pelvic straight is a cavity whose anterior wall is missing. And the straight lines between the plane of the pelvic dimension is banded by the lower border of the symphysis pubis. The lower border of the pubic symphysis. The ischial spines by the sides and the tip of the sacrum posteriorly. While the anatomical outlet of the pelvis, the anatomical aspect of the side stretches between the lower border of the symphysis pubis along the pubic rami to the ischial tuberosity and to the top of the coccyx bone. These are the boundary of this lower pelvic straight, or what we call the obstetric outlet. The inferior border of the pelvis through the pubic rami to the ischial tuberosity ligaments to the top of the coccyx posteriorly. The levator ani muscles, which are the part of the expulsive muscle in the pelvic floor, arises from this line of the plane of the least pelvic dimension. Internal rotation of the presenting parts occurs at this plane in labor. The mid-pelvic straight lies between the upper straight and the lower straight. The mid-pelvic straight lies between the pelvic brim and the plane of least pelvic dimensions. And the anterior surface of the sacrum comprises the posterior wall of the cavity. The anterior surface of the sacrum comprises the posterior wall of the cavity. And anteriorly is bounded by the posterior surface of the symphysis pubis. Anteriorly. And posterior wall of the cavity is longer. The posterior wall of the cavity is longer than the anterior wall. You can imagine the length of the sacrum to the length of the pubic symphysis. So that's why the posterior wall is longer than the anterior wall. The plane in the middle of the cavity is usually larger than any of the other pelvic planes. You remember? I said the plane of the pelvic plane is just round. It's plain. There is no cavity at all, no depth. Right? And the lower pelvic plane, the anterior wall is very deficient. Very deficient. Yes. From the plane of the pelvic brim, to the plane of the anatomical outlets below, the pelvic axis resembles that of a drain pipe end. A drain pipe. So you can look at it, it's like a pipe down. And it is round. It is round all over. Just looking at it, it's round. And in the middle as a circle. at the lower end has oval whose longest diameter runs anterior-posteriorly. Again, the pelvic axis, if you look at it from the plane, from the top, the plane of the anatomical outlet, the pelvic axis resembles that of a drain pipe. And each of the pelvic straits will be considered as a hoop. Thus are the inlet as an oval whose longest diameter runs transversely. That is, the transverse diameter of the inlet is longer than the anterior-posterior diameter. And in the middle, looking at it as a drain pipe, the middle of it looks like a circle. And at the lower end, as oval, whose longest diameter runs anterior-posteriorly. Look at it. At the inlet, the transverse diameter is longer than the anterior-posterior diameter. In the middle, the diameters, the anterior-posterior diameter and the transverse diameter are equal. And outside, down at the lower pelvic plane, the anterior-posterior diameter is longer than the transverse diameter. All this structure that the picture I've painted depicts of a normal pelvis, normal female pelvis, normal that is called a gynecoid pelvis. These are the dimensions that I've just read. The anterior-posterior diameter, I said, is 11.5 centimeters. And the transverse diameter is 13.6 centimeters. So the transverse diameter is longer than the anterior-posterior diameter. And in the mid-straight, the mid-pelvis, all diameters are equal, 12.0 centimeters. The AP is 12, the transverse is 12. And lower down at the outlets, the AP is 12.5 centimeters and the transverse is 10.5 centimeters. You may ask me why this is so. When the baby is in labor or very late in pregnancy, the head tends to occupy the largest diameter. So at the brim, before descent takes place, the head is in transverse, that it occupies that transverse diameter where there is much room. And as it descends down into the pelvis, into the middle of the pelvis, where all the diameters are normal, are okay, 12.0 centimeters, it comes down. And with further descent, when the head of the baby is about to come out of the pelvis, the anterior-posterior diameter is larger than the transverse diameter. So the head of the baby now occupies the anterior-posterior diameter in a bid to come out anytime. So that's why you need to observe, to note these dimensions very well. The discussion so far that I've described is that of a normal female pelvic called a gynecoid pelvis. It's called a gynecoid. The normal female pelvis is a gynecoid pelvis. This type of pelvis is found in about 50% of all women. And it is most favorable for uncomplicated vaginal delivery. It is most favorable for uncomplicated vaginal delivery. And it can be found in about 50% of all women. The pelvic inlet is oval in shape. The transverse diameter slightly greater than AP, as I've said. The transverse diameter is about 13.6 and the AP is about 11.5. The pelvic side walls are straight. The ischial spines are not prominent. And subpubic arch, that is beneath the inferior region of the pubic symphysis, the subpubic arch is wide. It can accommodate 2 fingers. And the sacrum is concave. So these are the characteristics of a normal gynecoid pelvis. And then coming to our topic of contracted pelvis. Contracted pelvis can be defined anatomically and it also has an obstetric definition. Contracted pelvis has anatomical definition and obstetric definition. Anatomically contracted pelvis is one where essential diameters of one or more of these planes are shortened by 0.5 centimeters or more. Like for instance, if you have the transverse inlet, if the inlet is 12, the transverse of the inlet is 12, and the AP is 10, of course, that shows there is a contraction at the pelvic inlet. So, anatomically, where the diameters of one or more planes are shortened by 0.5 centimeters or more, we talk of anatomically contracted pelvis. And the obstetric definition is when alteration in size and shape of the pelvis is of sufficient degree so as to alter the normal mechanism of labor in an average sized baby, we talk of obstetrically contracted pelvis. Two definitions of the contracted pelvis, anatomically and obstetrics definition. The anatomically is about absolute dimensions, the diameters of those that can be taken at either Cephalopelvimetry or CT pelvimetry, computerized tomograph pelvimetry, or X-ray pelvimetry, or magnesium resonance imaging. Once the diameters of these outlets are shortened by 0.5 centimeters or more, then we talk of contracted pelvis. Or if there is alteration in size and shape of the pelvis in a degree as to alter the normal mechanism of labor in an average size baby, then we also talk of obstetric definition of contracted pelvis. What about cephalopelvic disproportion? Cephalopelvic disproportion can be defined as absolute cephalopelvic disproportion or relative cephalopelvic disproportion. But cephalopelvic disproportion by itself is the presence of disparity between the diameters of fetal head and the dimensions of the maternal pelvis. Again, cephalopelvic disproportion is the presence of disparity between the diameters of the fetal head and the dimensions of the maternal pelvis. It is absolute if the disparity between the fetal head and pelvic exists in the presence of optimal fetal head diameter, in the presence of a normal fetal head diameter. And it is absolute when an abnormal position of the fetal head results in the presentation of a head diameter too large to pass through the pelvis. That's relative, because that we're talking about abnormal position, like an occipitopostural position, for instance, or a face presentation. When we have such type of presentation, such type of abnormal position, a larger diameter of the presentation is present to the pelvis, and this can limit the passage of the fetus through the pelvis. But in absolute, what you have is that the fetal head is present, but there is some degree of disparity between that fetal head and the pelvic dimensions in the presence of a normal fetus. Variation of female pelvis. We have just talked about gynecoid pelvis. We said it's a normal female pelvis in about 50% of cases. But occasionally, we may have alterations in these pelvic inlets. And we have three major alterations that can take place. There is what we call android pelvis, or what we call male pelvis, android type. Unlike the gynecoid pelvis, which is round, which is oval at the inlet, the inlet of the android pelvis is wedged, and it goes down like a cone with convergent walls, convergent side walls. The ischial spines are very prominent. The subpubic angle is narrow, and the sacrum is inclined anteriorly. The sacrum is inclined anteriorly. Remember, we say that of the gynecoid pelvis, the inlet is over. There is these pelvic side walls are straight. They are not convergent. They are not that, but straight. The ischial spines are very minimal, not prominent, and the subpubic angle is wide, and the sacrum is concave. If you compare, you can easily compare the two between gynecoid and android. Gynecoid android pelvis occurs in about 27% of cases. It occurs in about 27% of cases. Android type of pelvis occurs, or the male type of pelvis occurs in about 27% of women. And android pelvis usually are associated with persistent occipito-postural position and transverse arrest because of the convergent nature of the side walls. They cone down. The pelvis cones down like a cone. So transverse arrest, persistent occipito-position are the major features of android pelvis. The next variation is platypeloid pelvis. Platypeloid pelvis. That's called a flat pelvis. Flat pelvis that is present in 3% of female pelvis. Is present in 3% of female pelvis. And it has a very wide transverse inlet. The transverse diameter is greater than that of the anterior-posterior diameter. And this type of pelvis is associated with deep transverse arrest in labor. And the fourth type, or the third variant, is called anthropoid pelvis. Anthropoid pelvis, or what we call the type of apes pelvis. This type of pelvis that is seen in apes. Apes. The inlet is over, just like the gynecoid pelvis, but the AP diameter, the ape anterior-posterior diameter, is greater than the transverse diameter. The anterior-posterior diameter is greater than the transverse diameter. The pelvic side walls are divergent. The pelvic side walls are divergent. We talk the pelvic side. Look at in gynecoid, the pelvic side walls are straight. In android, they are convergent. In anthropoid, is divergent. And the sacrum is inclined posteriorly. The sacrum is inclined posteriorly. This type of anthropoid pelvis is associated with occipito-postural position, and we can always have a deep transverse arrest. But one important thing about the anthropoid pelvis is that it results from high assimilation, whereby the sacral bone is incorporated with the fifth lumbar vertebrae. So that means the AP, the anthropoid pelvis is longer than gynecoid pelvis or android pelvis and platypeloid because of that high assimilation that is seen with the incorporation of the sacral body with the fifth lumbar. Also, we can have occipito-postural position in this type of pelvis. Yes, we have noted 4 types of female pelvis, and we have said the normal is gynecoid, the variations anthropoid pelvis, platypeloid pelvis, and android pelvis. What then could cause contracted pelvis? What are the things that can cause contracted pelvis? What are the things that can cause contracted pelvis and probably cephalopelvic disproportion? Besides the variance of types of pelvis in women that we have mentioned, the android, platypeloid, and the anthropoid, other causes of contracted pelvis in one or more diameter include 1. Nutritional and environmental defects. Nutritional and environmental defects. For example, rachitic pelvis. rachitic pelvis. Rachitic pelvis is caused by rickets. Rickets is a disease of early childhood when bone remains soft and unossified. Rickets is so common in many developing countries, and usually they are due to deficiencies of vitamin D. Once there is deficiency of vitamin D, the absorption of calcium is limited. So the bones are not developed, the bones remain soft and unossified. Related to rickets is osteomalacia. Osteomalacia in adults. In osteomalacic pelvis, there is softening of the pubic bone due to calcium deficiency and lack of exposure to sun rays. Both osteomalacia and rickets will lead to contracted pelvis. And this is a problem in many of the developing nations. In Africa, it's so common. Rickets and osteomalacia are very common. The second, apart from these variants of types of pelvis in women, are the diseases and injuries to the pelvis. Diseases and injuries to the pelvis. First, fracture, pelvic fractures. Pelvic fractures, tubercular arthritis, tubercular arthritis resulting from tuberculosis. In Africa, we have high prevalence of tuberculosis, and we have tuberculous bones that will affect the shape and size of the pelvis. Spine kyphosis, or spine scoliotic conditions of the spine. Spondylolisthesis, coccygeal deformity, poliomyelitis, and hip joint diseases are some of the diseases that can affect the integrity of the pelvic bone. They can affect the integrity of the pelvic bone. And these deformities can cause asymmetrical or obliquely contracted pelvis. It can cause asymmetrical or obliquely contracted pelvis. There could be congenital problems that can lead to asymmetrical or obliquely contracted pelvis. And one of them is the congenital absence of one ala of the sacrum. The ala of the sacrum is that triangular fissure at the portion of the sacral promontory. Up is just a triangular bony structure on both sides of the sacral promontory. Ala. So when one of them is absent, we talk of Naegele's pelvis. Naegele's pelvis. When one ala is present, it can cause asymmetrical. And in robot pelvis, the two ala of the sacrum are absent. And the sacrum is just fused with the innominate bones, straight with the pubic bone, or the sacrum. The sacrum is just fused with the pubic bones, and it leads to asymmetrical contraction of the pelvis. Please note these two congenital malformations: Naegele's pelvis and robot pelvis. They are rare, but they do occur. But by far, in our environment, fractures resulting from road traffic accidents could be a major cause of contracted pelvis. Nutritional, followed by nutritional problems arising from childhood or even arising from adults. How do you diagnose contracted pelvis? Usually, diagnosis starts from clinical history. Diagnosis starts from clinical history and physical examination. Diagnosis starts from clinical history and physical examination. A previous history of fracture, either from infancy or childhood, may be a pointer to a contracted pelvis. History of previous rickets or previous osteomalacia or previous tuberculosis of the spine, or pelvic joint, or poliomyelitis will be a pointer to the development of contracted pelvis. And even without taking history, you might actually observe a poliomyelitic patient. You can see them, it's obvious. Rickets also, you can easily make a diagnosis. Even the way the woman walks, the way she walks, the gait of the patient may give out that diagnosis. And the measurement of the height and weight of women may also give you an insight as to whether a particular woman may have a contracted pelvis. Small woman of less than 5 feet in height is likely to have a small pelvis. Small woman of less than 5 feet is likely to have a small pelvis. So, taking history and general physical examination, history of tuberculosis in childhood, history of rickets, history of osteomyelitis, history of fracture, combined with the history, with the weight measurement and the height, they could be enough pointer to diagnosis of contracted pelvis. And again, you may have to supplement with further clinical examination of the pelvis. So when you are assessing for adequacy of the pelvis clinically, with the aid of your hand, you are talking of clinical pelvimetry. You are assessing for the adequacy of the pelvis. Using your fingers, to assess the pelvic inlet, to assess the mid cavity of the pelvis, and to assess for the outlet of the pelvis. What you are doing is a clinical pelvimetry. In very experienced hands, clinical pelvimetry is very, very accurate, and there may not be even any need for an X-ray pelvimetry or a CT pelvimetry or magnetic resonance imaging techniques, if available. Yes. So, what are the things that we do in clinical pelvimetry? What are the things that we do in clinical pelvimetry? The first thing that we do is to assess the pelvic inlet. We assess the pelvic inlet. When we are describing the gynecoid pelvis, we talked about the boundaries of the pelvic inlet. We said the posterior relation is what? Is the sacral promontory, and anteriorly is bounded by the posterior border of the upper surface of the pubic symphysis, and laterally by the iliopectineal ligaments. In assessing the diagonal conjugate, in assessing the pelvic inlet, we talk about three conjugates. The diagonal conjugate, the obstetric conjugate, and the true conjugate. The diagonal conjugate is obtained by measuring the distance from the lower edge of the pubic symphysis to the sacral promontory. Usually, the distance from the pubic symphysis to the sacral promontory should be at least 12 centimeters or thereabout. 12 centimeters. And it's nice that any clinician that wants to do this must know the exact measurement of the tip of his middle finger, to be able to measure it to the last origin of the thumb. My own is about 11.5. So each time you put your hand to do a vaginal examination and want to approach the sacral promontory, if you can easily reach the sacral promontory, that means if you can easily reach it, you must be suspicious of a contracted inlet. But if you cannot reach it easily, it shows that pelvic inlet may be adequate. So the distance of the pelvic symphysis, inferior border of the pelvic symphysis to the sacral promontory will give you the diagonal conjugate. And most of the time, it's between 11.5 and 12 centimeters. And the obstetric conjugate is from the superior border of the pelvic symphysis. You know, your hand is beneath the pelvic symphysis, you see 4 border, and you can measure the obstetric conjugate from the superior border of the pelvic symphysis to the sacral promontory. But most of the time, you can only get this information from X-ray pelvimetry, because there's no way you can measure that from the upper border of the superior border of the pelvic symphysis to the sacral promontory. And usually, the obstetric conjugate is shorter than the diagonal conjugate. It's about 1.5 to 2.0 centimeters less than the diagonal conjugate. And the true conjugate is the distance between the mid portion of the pelvic symphysis to the sacral promontory. And at all times, it should be more than 10 centimeters. If the true conjugate is less than 9 centimeters, we are talking of grossly contracted pelvis. True conjugate less than 9 centimeters is highly suggestive of a contracted pelvis. Yes, in assessing the mid cavity, we want to concentrate on the pelvic side wall. In a normal gynecoid pelvis, we are saying that the pelvic side wall is straight. So, in assessing the mid pelvis, we want to assess whether the pelvic side walls are straight or whether they are convergent or divergent. Convergent, if it's convergent, you are thinking of what? Of android pelvis. Divergent, talking about anthropoid pelvis, right? But usually the platypelvic pelvis, though wide, short, tends to have a feature similar to that of gynecoid pelvis. And again, you need to palpate the ischial spines. You palpate the ischial spines for prominence. As we have said earlier, the gynecoid pelvis has the ischial spines are not prominent. But in android pelvis, the ischial spines are prominent. They are prominent. And look at the concavity of the sacrum. In android pelvis, the sacrum is not concave, but a little bit convex. That's why the sacrum is pointing posteriorly. So this is what you look for when you are assessing the mid cavity. Yes, how do you assess the pelvic outlet? The pelvic outlet, there are two major things that we do with the pelvic outlets: the intertuberous diameters and then the palpating the subpubic arch. The intertuberous, in a woman that lies dorsal with the legs flared and abducted, what you need to do is to insert your knuckle between the two ischial tuberosity. You insert your knuckle, and if the intertuberous diameter can take at least 4 fingers, you will say that outlet is normal. That is, that's 8 centimeters, assuming that one finger is about 2 centimeters. So a knuckle of 4 fingers, if you can accommodate the knuckle, therefore that. But if you cannot accommodate all the knuckle, so that outlet is not very adequate. And then you palpate the subpubic arch. Put 2 fingers. The subpubic arch must be able to accommodate 2 fingers. That should be wide enough to accommodate 2 fingers. So with that, you know, but if you cannot accommodate 2 fingers, that means that subpubic arch is acute, and it's not likely that the pelvis is adequate. So 3 things clinical pelvimetry involves: assessment of the pelvic inlet, the mid cavity, and then the pelvic outlet. With the pelvic outlet, just accommodation of the knuckle easily will depict or denote that the outlet is adequate. And if you put 2 of your fingers at the subpelvic, I can easily accommodate it, fine. That means the outlet is adequate. So we have to combine all those things to make a very good assessment. And it's possible when you are doing this that one aspect there may be disparity between the pelvic inlet or the mid cavity. There may be some degree of disparity. It's possible for the pelvic inlet to be normal, mid cavity to be normal, and then the pelvic outlet to be abnormal. So we have to look at everything and use these 3 planes to assess whether the pelvis is adequate or not. In labor, there is something we call Hill's-Muller test. We only do that when a patient is in labor at pelvic examination. What we do there, in labor, when the woman comes and you are suspecting contracted pelvis, the accoucheur or the physician puts his left hand on the fundus of the patient, while the right hand is in the vagina. While the right hand is in the vagina, the accoucheur tends to push the uterus, the fundus of the uterus down, as to see whether the head of the fetus will enter into the vagina. And if the head of the fetus enters into the vagina, then the right hand will feel the movement of the head in the vagina. So if the fetal head enters into the vagina and the accoucheur feels the movement of the presenting part, that means the probability of cephalopelvic disproportion or contracted pelvis is very, very low. Once the head can pass into the pelvis, that means there is no cephalopelvic disproportion or a contracted pelvis. But if there is no down movement felt, while the fundus is pushed down, and there is no downward movement below, the possibility of cephalopelvic disproportion or contracted pelvis is very high. This is Hill's-Muller test. There is what we call Morocco's method. Morocco's method is similar to Morocco's method is similar to Hill's-Muller method, but this is a screening method that is done antenatally before the woman goes into labor. Hill's-Muller test is done in labor, but Morocco's method is not done in labor. While the woman is lying on her back in a dorsal position, the left hand grabs the head of the baby with the right hand in the vagina. With the right hand or the middle finger and the index finger lies on top of the pubic symphysis. The middle finger and the index finger lies on the top of the pubic symphysis, and with the left hand trying to push the head into the pelvis to see if there be overlapping of the parietal bone between the head, whether there is going to be overlapping of the fetal head with the pubic symphysis. If the head of the baby is pushed into the pelvis without overlapping, obviously there is no disproportion. No disproportion. If the head could enter into the pelvis, there is no overlapping. But if the head is pushed down, but there is slight overlapping of the parietal bone, that shows a degree of moderate disproportion. If the head cannot be pushed down at all and it overhangs the pubic symphysis, this shows severe disproportion. This shows the severe disproportion. I repeat, if the head is pushed down into the pelvis without overlapping, that shows no disproportion. But if there is a little movement, if there is a slight overlapping of the parietal bone, there is moderate disproportion. If the head cannot be pushed down at all and it overhangs the pelvis, there is severe disproportion. As I said, this is useful in the antenatal period to determine whether there is some degree of contraction of the pelvis or whether there may be either cephalopelvic disproportion may occur in labor. It's a screening method and it's very useful, particularly in first-time pregnant women. First-time pregnant women, very, very useful. Or in women who has had a previous cesarean section for a non-recurrent indication. A woman who has had a bled from placenta previa or abrasive placenta in previous pregnancy, she had a cesarean section and she's coming back to have a cesarean section. You may want to use this Murokes methods to exclude contracted pelvis or cephalopelvic disproportion. And again, this clinical method, as I said, in very experienced hands is very, very useful. You may not require the need for X-ray pelvimetry. Apart from clinical pelvimetry, then we have radiological pelvimetry. The first that is so common in many of the developing countries is what called X-ray pelvimetry. X-ray pelvimetry. The use is now limited. To vaginal breech delivery, if we are planning for assisted vaginal delivery, or vaginal birth after cesarean section, or in patients with gross body distortion caused by trauma, rickets, or osteomalacia. Those are the three conditions where X-ray pelvimetry is now useful. The use of X-ray pelvimetry is now limited because we know that the technique is not accurate. The technique of X-ray is not accurate. We always request for a lateral X-ray pelvimetry. But by the time you do a lateral X-ray pelvimetry, you expect the bones to overlap as not to see the left or the right. But in most cases, when you do X-ray pelvimetry, the legs, you can see the left and the right femur, and that's not good enough. So it gives a very wrong impression. It's not adequate enough, and there is a risk to the fetus of exposure to radiation. There is a risk of the fetus being exposed to radiation, and this X-ray pelvimetry as well may increase the cesarean section rate. It may increase the cesarean section rate. So its role is limited. It's limited in modern obstetrics. The next one that we'll go to in pelvimetry is computerized tomographic scanning. Computerized tomographic scanning that we call CT scan. Here, there is less radiation when compared to the use of X-ray pelvimetry. There is less radiation when compared to the use of X-ray pelvimetry. But there is greater accuracy. There is greater accuracy and can be easily performed. But it's very, very expensive. Very expensive. The third type of X-ray pelvimetry that we can do is magnetic resonance imaging. Magnetic resonance imaging. And this magnetic resonance imaging has a lot of advantages over the X-ray pelvimetry and CT pelvimetry. It has a lot of advantages over CT pelvimetry and X-ray pelvimetry. The first that there is lack of imaging radiation to the fetus and even to the mother. There is lack of imaging radiation to both mother and fetus. It's more accurate. It's more accurate than CT pelvimetry and X-ray pelvimetry. And you can do a complete fetal imaging. This CT magnetic resonance imaging, MRI, can do a complete fetal imaging in such a way that you can diagnose fetal congenital anomaly in the fetus. For instance, you can cyst in the neck or spinal problems with the spinal cord. You can easily make a diagnosis, or even in the anterior abdominal wall with magnetic resonance imaging. And again, it can be used for potential evaluation of soft tissue dystocia. We have said the passage has soft tissue components and a bony component. But the problem with MRI too is even more expensive than the computerized tomography scanning. Very expensive, but has a lot of advantages over that. Yes, we have been talking about how to diagnose cephalopelvic disproportion or contracted pelvis through history and physical examination, clinical pelvimetry, and spirometry. What are the signs of cephalopelvic disproportion? What are the signs? One, abdominally, the presence of a large fetal size. The presence of a large fetal size. Maybe a plethoric baby, a large baby, baby with big head, like the babies born to diabetic mothers or babies born with rhesus isomionization. You may suspect cephalopelvic from their size alone, because if the head is big, you can easily suspect. Fetal head overriding the pubic symphysis, as we have talked about in Mueller's test or in the Morockel approach. Fetal head overriding the pubic symphysis. When you do that, you can suspect cephalopelvic disproportion. At pelvic examination, cervix shrinking after menstruation. When you do your amniotomy, you break the liquor and the fluid come out. Instead of cervix, it just shrink. That shows that, of course, there may be a problem with one of the early signs of CPD. Head not well applied against cervix. If the head is high and the cervix is far away, the cervix will not dilate. So head not well applied against cervix is an early sign. Head not engaged, the same thing. Caput formation, molding, deflection, and asynclitism. Asynclitism just means that the sagittal suture at the time of the asynclitism, the sagittal suture should be in the anterior posterior AP diameter of the pelvic axis. So when the sagittal suture is more displaced to the left or to the right and not at the center, you are talking of asynclitism. And other signs may be maternal pushing before complete dilatation. The mother is trying to push out the baby before the cervix is completely dilated. Then early deceleration of the fetal heart may be the negative Mueller's test or the reverse Mueller's test that I've referred to as Morockel method. All these are evidence, are signs referable to cephalopelvic disproportion. So, what are the causes of labor in contracted pelvis? What are the causes? What's the pattern? What's the outcome in contracted pelvis? In labor, the head may just be floating. With no descent in labor at all. So no matter how well contracted the uterus is, there is no descent of the fetal head in labor. The head remains floated for a long time. So people will call you, oh, this head has not descended into the pelvis. That's one of the things that you say. Secondly, if there's some progress, the woman is contracting well, it gets to a stage where the labor will be obstructed or prolonged. So it may end up in prolonged obstructed labor with considerable molding and caput formation. It may end up in prolonged and obstructed labor with considerable molding and capillary formation. After prolonged obstetric labor, the labor can still continue. There may be thinning of the lower uterine segment with development of Bandan's retraction ring. Thinning of the lower uterine segment with development of Bandan's retraction ring that can eventually lead to uterine rupture. And lastly, with severe prolonged obstetric labor, because of period necrosis, there could be development of vesicovaginal or rectovaginal fistula. This is a common problem in African countries where we have the highest number of vesicovaginal or rectovaginal fistula in the world. And usually, they almost always arise from complications of prolonged obstetric labor. So these are the 4 things you can see. Obvious, the head of the baby remains floated in the pelvis with no descent in labor. It can be prolonged. The labor can be prolonged and obstructed. The lower segment of the uterus can become thinner, leading to Bandan's retraction before the uterus ruptures. Then vesicovaginal or rectovaginal fistula may result due to period necrosis. Management of labor in cephalopelvic disproportion. Management of labor in cephalopelvic disproportion. If the condition is detected, if there is evidence or the sign is detected in labor, if detected during labor, in which case that CPD was not diagnosed prior to labor, emergency cesarean section may be done if the fetus is alive in a very good condition. Emergency cesarean section may be done if the fetus is alive or the mother is stable. Occasionally, the cephisotomy can be done by if the head is actually very down, you can see the head, but there is no progress in the baby coming out. You can make an incision into the pubic symphysis to enlarge the uterus and deliver the baby. Thirdly, you can use your ventus application as well. You can use your ventus application and see if you can use your ventus to deliver the fetus. And in this circumstance, never use forceps delivery because of the space. Never use forceps. A ventus application is a better alternative. And if the baby is dead, you can do any of the destructive operations, preferably craniotomy. Craniotomy may be the right type of destructive operation that can be done. If CPD is suspected before the onset of labor, it's preferred to do elective cesarean section. And in my practice, sometimes when I suspect it, I do a clinical pelvimetry. And if I find the clinical pelvimetry, I do the diagonal conjugate. And if it's less than 10 centimeters, if I think it's less than 10 centimeters, then I will resort to cesarean section, elective cesarean section. And I will consider for all cases, I will do for all primary gravidas with suspected cephalopelvic disproportion, I will prefer to go for elective cesarean section. The same way I will do all malpresentations, I would consider elective sections. Or patients with contracted pelvis and also significant degree of outlet contraction if decided to go for elective cesarean sections. Premature induction of labor is not to be encouraged. It's something that people do in the past, but we do not encourage it. But occasionally, in borderline pelvis, with history of previous delivery, it can be done. It can be done. Trial of labor, again, something that can be considered with close monitoring in spontaneous labor only. Close monitoring in spontaneous labor only, not an induced labor, but with spontaneous labor. And trial of labor should not exceed 6 to 8 hours. Trial of labor should not exceed 6 to 8 hours. And trial of labor should be terminated if there is any challenge like prolonged labor or signs of fetal distress or pathographic abnormality in labor. Contraindications to trial of labor. I've said that. Contraindications to trial of labor. Elderly primigravida is number one. Elderly primigravida. Women delivering after 35 years. Elderly primigravidas. Do not consider trial of labor. Very risky. Malpresentations, heartless contractions, preeclampsial hypertensive disorders, cardiac or pulmonary disease, or true conjugate less than 9 cm, and failed previous trial of labor. Thank you for listening, and that brings us to the end of the session today.